Welcome, everyone. So we're just going to wait a few more minutes to get started, let people join the meeting or webinar.
I believe we got everyone except one panelist. It did start recording.
Do you know if we'll be able to turn our video on when our presentation starts?
Yes.
Okay, thank you.
I will make you a co-host when that happens.
Thank you.
Nicholas, as we get started, would you like to review the technical details of today's session?
Yeah. Basically, I will make each participant or panelist a co-host as it becomes their turn, and then they should be able to share their screen at that point. Other than that, I'm just sort of behind the scenes, making sure that the technical stuff kind of runs smoothly as far as transitioning from one host to another for sharing the screens.
Fantastic. So since we're all here, I just want to welcome us to our session this afternoon. My name is Professor Kristin Yarris, and I'm a professor in the Department of Global Studies. I also direct the Global Health Program. And Nicholas Mahllum is our moderator number 2 behind the scenes helping with tech, and appreciate everyone being here this afternoon with us. So our first presenter is Dimitra Fellman, and she will introduce her project title. And we're really happy to have you in our session this afternoon called Pandemic Response.
And I have you as a co-host, Dimitri, so you should be good to go.
Great, thank you for the introduction, Dr. Yarris. Hi, my name is Dimitra, and let me see if I can share my screen. All right. Great. Hi, everyone. My name is Dimitra, and today I'm going to be presenting on my undergraduate thesis research, which is approaches and outcomes to COVID-19 testing in Oregon from March to September of 2020. I'd like to thank the Office of the Vice President for Research and Innovation and the Robert D. Clark Honors College for providing financial support for this research. In my research, I focus specifically on COVID-19 diagnostic tests. These are tests that are used to determine whether or not someone has had the SARS-CoV-2 virus, which is the virus that causes COVID-19, in their body. Diagnostic testing was a critical tool for tracking and combating the spread of COVID-19, especially when there were no vaccines or treatments. Diagnostic testing allowed health authorities to determine who is infected and potentially exposed, and then subsequently isolate and quarantine those individuals to prevent further transmission. The purpose of my thesis is to assess how appropriately the state of Oregon and its public health department, the Oregon Health Authority, approached COVID-19 testing. My focus is on Oregon because in the US, there was a decentralized response, and so decisions were made on a state-by-state basis. Hence my decision to focus on one state, Oregon. Within Oregon, I'm focusing on the Oregon Health Authority as they are the state level public health department and led the state's COVID-19 response and informed government decisions, which made them the most important players. In general, the role of public health departments is to measure, explain, and improve the health of the population. This includes more specifically generating data for decision-making and public consumption and promoting health equity. Based on these roles, I'm defining an appropriate response as one that involves 2 things. 1, using data collection methods and producing data of a quality that's suitable for the decisions it's being used to make, and that information is subsequently well communicated to the public. Secondly, that there is an ethical allocation of resources based on the notion of equitable access. In order to determine if Oregon's response met these criteria, I asked the following questions. How did the Oregon Health Authority collect and report testing data? How did data influence the public and political decisions? And what were the implications of data inaccuracies? I also asked what was the logic, rhetoric, and data driving protocols determining how COVID-19 testing resources were distributed and who would get tested? And did those protocols result in an ethical distribution of testing? I argue that testing data was misconstrued by the Oregon public and misused by state and public health officials because the context and process by which the data was generated was not fully appreciated or communicated. I also argue that the distribution of testing supplies and diagnostic tests was unethical because distribution in Oregon was not based on proportionate need and because existing barriers to accessing tests were not reduced in a way that facilitated proportionate distribution. In order to come to these conclusions, from March to September of 2020, I conducted daily searches for information and data in diagnostic testing. My final data set draws from documents that are publicly available from government, county, and medical provider websites, internal government documents that I obtained through public records requests, such as these email communications or Excel spreadsheets, and then also news conferences and press conferences with Oregon Health Authority and government officials that were published to YouTube, as well as articles from state and local newspapers. I then analyzed the data for specific information that would answer my research questions and took note of patterns and trends. In addition to my own primary research, I drew on two types of literature to provide context and further support my claims. The first are ethnographies on data, and these focus on the context under which metrics are created and shaped as they develop into a final publicly presented form. And the conclusion from the three ethnographies that I drew from, which are shown here, are that the process of generating data creates truth and knowledge and does not accurately or completely reflect what it aims to capture. And the authors argue that this is because arbitrary assumptions are made in how data is collected and processed that can lead to different results. The authors also demonstrate how often subpar data is validated and used to inform political decision-making, which does have real-world consequences for societies. The second set of literature that I draw from is public health and medical literature describing how to ethically allocate resources during a pandemic. Public health literature argues that during a pandemic, public health authorities must, 1, address and give priority to those who are systematically disadvantaged, 2, provide resources to disadvantaged groups proportionate to the increased risk they face, which is seen in the image on the left, and 3, reduce barriers to utilizing those resources, which is conceptualized in the image on the right. The medical literature contributes by arguing that choices should not be made on a case-by-case or first-come, first-served basis, as that would further exacerbate inequality, which would be unethical. So again, drawing from this literature and my own research is how I arrived at my main arguments, which again are that testing data was misconstrued and misused, and that the distribution of testing supplies and diagnostic tests was unethical because distribution was not proportionate to need. So what is my evidence for these arguments? I've selected just some examples that I came across. The first is for my first argument, which is that testing data was misconstrued and misused. And one example is data on the number of tests performed in the state of Oregon. In Oregon, the Oregon Health Authority collected this data and decided to use what's known as a person-based reporting method as opposed to a test-based reporting method. And under a person-based reporting method, the unique number of people who are tested is what is counted, whereas under a test-based method, the actual number of tests given is what's counted. So in this example on the right, let's say there's a person who's tested 3 separate times. Under a person-based method, that person is counted once in the finalized metric as they are one unique person. However, using a test-based method, each of those 3 tests that person received is counted separately and their finalized metric is 3. And so it's easy to see how using a person-based method, which is what Oregon did, could lead to a large undercount in the number of tests performed, especially if people are tested more than once. However, the fact that Oregon was using a person-based method was not clearly communicated to the public, and as a result, the public as well as lawmakers thought that Oregon was not testing enough compared to other states. And this is showcased in many newspaper publications outlining Oregon's low testing rate. However, if one were to use a test-based method, it would have shown that Oregon was actually on par with other states. So this is an example of this false perception that's a result of poor understanding of data. Additionally, this data was misused by the state because it dictated what types of businesses and entities could hold in-person activities. However, Oregon was only using a person-based method to make these determinations, which was not comprehensive and did not necessarily paint a complete picture of Oregon's testing levels. Additionally, I found, for my second argument, found that the methods determining who would be allocated supplies were not based on proportionate need. And this was seen in the distribution of both private and public supplies. So for private supplies, Cepheid testing kits, which are just testing kits made by the company called Cepheid, in Oregon, their distribution was reflected in entities' size and purchasing power, and otherwise, a provider's ability to receive these testing kits was based on luck. For the distribution of public supplies, which was completed through the Oregon Ops Center in the state of Oregon, was based on what and how much a county was willing to ask for and facilitated distribution on a first come, first served basis. And this is because this system in Oregon is request-based. And so in both cases, in the distribution of Cepheid testing kits and the distribution of public supplies through the Oregon Ops Center, distribution was not based on proportionate need and was therefore unethical. There was a similar pattern of unethical distribution or unethical access to tests themselves. Access to tests did not align with proportionate need, and there was no reduction of barriers for groups that had difficulty accessing those tests. I think the case study that best showcases this is access among racial and ethnic minorities and those with a lower socioeconomic status. In Oregon, the Oregon Health Authority told Oregonians to contact their medical providers for testing. However, this assumes that someone already has a medical provider or knows how to find one through navigating complicated healthcare systems. And that meant that groups that did not fit these criteria were underserved. And these groups were disproportionately racial and ethnic minorities and Oregonians with a lower socioeconomic status. However, in the state of Oregon, there were not sufficient community testing events, which is diagnostic testing that happens for free outside the medical system, to make up for a lack of access through the medical system. Additionally, resources that were available to find tests within the medical system did not significantly reduce barriers for communities and individuals who had difficulty accessing those tests. This means that in Oregon, distribution wasn't proportionate to need because, for instance, it was well documented that racial and ethnic minorities had higher COVID-19 case rates, but in this case had less access to diagnostic tests themselves. It is important to note that I'm not calling out Oregon as having some sort of unique issue. The arguments that I presented here also apply at the federal level as well as to other states. So Oregon can really be thought of a case study of broader trends that need to be addressed. Additionally, even though I stopped collecting data on a daily basis after September of 2020, I did notice the same trend of ethical distribution of vaccines, whereby the distribution and access to vaccines was not proportionate to need. All of this leads to the conclusion that long-term investments and commitments need to be made to public health systems in order to achieve more appropriate responses to pandemics and epidemics in the future, as well as everyday health promotion. Thank you.
Thank you so much, Dimitra. So we have 1 or 2 more minutes for Dimitra's slot here in case anyone in the audience or attendees want to use the Q&A button. You can pose a question about Dimitra's presentation. If not, we will move on to the next presenter and we will have hopefully some time at the end for broader conversation. But we have a minute in case anyone had questions for Dimitra. I'll ask one, Dimitra, since I have the mic. What do you think OHA can do better from lessons learned from your study and examination of testing, RE, vaccine rollout, and reaching the population that's not yet vaccinated in the state?
Yeah, that's a great question. So I think, yeah, definitely some of the things that OHA can improve upon, I think is in terms of like outreach is related to clear communication. Obviously, it's a lot more complex with vaccines because there already has been well-established, vaccine misinformation that is spreading online. But I think one of the things that makes, that can be helpful is if the government does prove that they're having clear communication, then that makes them a more trustworthy source. And I think that's one of the things that kind of drives people towards alternative sources is that, there is, like I presented today, evidence that the state isn't always the best at communicating. And so that makes people not really want to lean on them as a trusted source. So I think that establishing that track record of being clear and effective communicators of information and data is important for that.
Thank you so much, Dimitra. It's great research that you've done.
Thank you.
Just to members of the audience, as the presenters are presenting, you can chat in using the Q&A function, any questions, and if we don't have time to get to them after their presentations, we hopefully will have time at the end of the session. So our next presenter is Anika Graack, and perhaps Anika, you can present the title of your presentation once you get it lined up here.
I've just made Anika a co-host, so she should be able to share her screen.
Thanks so much. Nicholas, I have a technical question. Do I have to stay unmuted?
I have it set to, I do have it set to mute everybody. It's best that you stay muted because the screen bounces back and forth to whoever's making noise.
Because I'm the host. Okay.
Yeah.
I just hope my office phone doesn't ring. If it does, I might mute myself.
No
Okay,
problem.
go ahead, Anika. Thank you.
Okay, thank you. Hi, everyone. My name is Anika, and today I'll be presenting my research, which is a comparison analysis of Spanish translated COVID-19 public health resources. I began this project over the summer with the help of Dr. Melissa Grayboys from my Clark Honors College thesis project. I'd like to begin my presentation by talking about the definition of a health disparity. A health disparity is when one group experiences an illness at a disproportionate higher rate than others. And there's been evidence of racial and economic disparities in COVID-19 morbidity and mortality rates across the United States. So for the economic disparities, counties and areas with lower income populations have been experiencing higher morbidity and mortality with COVID-19 rates. And additionally, there are racial disparities as well. One of these groups being the Latinx community, they're burdened with higher morbidity and mortality rates as well. And in addition to many systemic issues, it has been suggested that the Latinx community may be experiencing this disparity because of a language barrier. And this is further supported by data that found that Latinx individuals had less knowledge and understanding in how to prevent COVID-19 infection. So because of all this concerning data, I wanted to look at the possibility of a language barrier contributing to this issue and search for any differences between English and Spanish resources on public health websites. Specifically, in my research, I used resources from the CDC and the OHA. The Centers for Disease Control and Prevention and the Oregon Health Authority are both public health organizations. The CDC is a national level public health organization and the OHA is state level. And they, along with other public health organizations, have the goal of improving the health and healthcare of all people. And this is why they create and distribute resources and information about COVID-19, and why it is their responsibility to create equitable and accessible resources for the population. So for my project, I wanted to answer these specific questions. What differences, if any, exist when comparing English and Spanish COVID-19 resources? And what differences, if any, exist when comparing Oregon Health Authority and Centers for Disease Control and Prevention resources in both English and Spanish? And through my research, I did find significant differences in the amount of information available in Spanish when compared to English. There were less resources available in Spanish on both of these websites. Additionally, I found differences when comparing the CDC to the OHA. The CDC had more Spanish resources available, but a lower proportion of their documents translated. And while the OHA had less total Spanish resources available, almost all of the resources were translated. And then just to give everyone a better idea of where I found my resources, on the OHA website specifically, I went to their COVID-19 pages and then clicked this Community Resources tab. because these resources are what the OHA has decided is important for the public and our community to know. And similarly, on the CDC website, I went to their COVID-19 page and sorted by print resources. I further narrowed this down to be the documents tagged as general public because, again, this is what the CDC has decided is important for everyone to know. And here I just wanted to show you all an example of what these resources look like so you can have a better idea. This example specifically is from the OHA. The left side is the English version and the right side is the Spanish translation. And here's an example of a resource from the CDC, again, showing the English and Spanish version. And for my project, I collected documents throughout fall term, so from September to December of 2020. So my project only includes documents published before 2021. And at the time of this study, there were 29 English documents with 25 Spanish translations on the Oregon Health Authority website. And there were 57 English documents with 28 Spanish translations on the CDC website. And for my analysis, I used Henry Fishback's recommendations for medical translation. He outlined several best practices and recommendations for this field. And more specifically, within each document, I analyzed the following categories. So I analyzed the audience by looking at the title, the content, as well as sometimes the website classified themselves what their intended audience was. I also analyzed the theme by again looking at the title and content. Some of the most common themes were masks, social distancing, and just in general how to protect yourself from COVID. I also looked at the content by determining if the information within the Spanish and English versions were the same. I also analyzed language by looking at conjugation forms, vocabulary relating to COVID-19, any medical vocabulary, as well as the presence of English in any Spanish documents. I also looked at the difficulty of documents by examining the conjugation forms, the words per sentence, and the number of sentences in the document. I had to make a few assumptions when looking at the difficulty of documents because while in English there is already an established parameter and system to classify the writing level, in Spanish this does not exist. And lastly, I analyzed the layout of these documents by looking at the presence of images, the size of images, the size of text, and the amount of white space on a page. And for each of these categories, I compared OHA Spanish and English documents to one another, CDC Spanish and English documents to one another, and OHA and CDC document sets to one another. And in this research, I think the most important finding is that there's just not the same amount of information available in Spanish when compared to English on these websites. The CDC have more documents total available in Spanish, however, a much lower proportion, only approximately half, while the OHA translated almost all of their documents. Additionally, unfortunately for translations that exist, many Spanish documents were published after the English versions, which means that Spanish speakers may have had to wait longer to get important information. The majority of translations do follow best practices on a more positive note. So for example, all of the Spanish translations have the same information as the English versions. Additionally, medical terms are defined when used and acronyms are explained in the documents. And lastly, there's evidence that both organizations did adjust their documents based on their intended audience. However, there were a few instances where Spanish documents have English terms in them. So here are some examples of English phrases that were included in some Oregon Health Authority Spanish translated documents. And while some of these phrases may be well known to people in Oregon, such as OHSU Children's Hospital, or some phrases may be easy to determine what they mean, such as the word doula in a document all about pregnancy and birth. It would be better in the future to translate everything within a resource to make it as easy as possible for the reader to understand. And also to align with best practices for medical translations. Additionally, as I mentioned previously, there is evidence that both organizations did attempt to change the layout of resources based on their audience. So this is a table showing how layouts differ based on audience. Specifically, this shows 6 resources from the CDC, where the 3 on the top are targeted towards adults and the 3 on the bottom are targeted towards children. And we can take a closer look at these documents targeted towards adults. You can see there's a lot of text on the page. The text is small, and each paragraph has a picture or icon that correlates with it. Additionally, there's not a lot of white space on these pages. And we can contrast this to the documents that are targeted towards children, where here the text is much larger and there's less text. The images are also larger and there's a lot more white space on each page. And lastly, the actual language used is different. So here with the documents for adults, if there are any Spanish speakers, you may recognize that the main conjugation form here is the usted form, which is the formal you form. Comparing that to the documents for children, which mainly use the to conjugation form or the informal you form, which is standard to use when addressing children. So from these different layouts, you can see that the OHA did consider their audience when creating these documents. And if we were to compare CDC documents as well, you'd see a very similar pattern. Overall, I think this research shows that the role of public health organizations is crucial to protecting minorities. It emphasizes the importance of medical translation and disseminating information in multiple languages, because if we want to use information as a way to mitigate illness, it should be available in all languages. I also think that there's a lot of potential for future research. It would be very interesting to repeat this style of study on documents from different organizations. I also want to point out that these websites are not the only places where Spanish speakers may be getting info about COVID and may not even be the most common ways to get information about COVID. Other people may be looking to social media, the news, the radio, or other websites. So it'd be very beneficial to study how the majority of the population is getting that information and then study those sources. Additionally, as I mentioned previously, there is no clear difficulty classification system in Spanish for the writing level of passages. It would be interesting to develop one and then analyze documents with it, because oftentimes medical translations are written at a higher reading level than many people are capable of fully comprehending. And lastly, while Spanish is the second most popular language in the United States behind English, there are several other languages with millions of speakers, and so it would be helpful to study what resources they have available in those other languages as well. Thank you so much.
Thank you, Anika. Excellent presentation. So any questions for Anika's research? We have a couple moments here. I'm tasked with timekeeping, so I will guide us through the afternoon here.
At the moment, no questions in the Q&A.
Anika, I will ask one then. I'll always have questions. I loved listening to your research and I thought your content analysis was really compelling. Do you have a sense whether, having been involved in some of this work myself the last year, that text-heavy message is landing? It struck me that the infographic with less text designed for children might even be more readily accessible to everyone. What do you think about that text-based infographics versus the more image-based? Do you have a sense of which one might have better uptake or understanding in the population?
Yeah, through my research, I did find in my literature review that when images are used in public health resources or medical resources, there does tend to be a higher understanding for the audience. So I think it is always best to include images. And I do love that the children's documents are so condensed, they get straight to the point. But if someone is looking for more in-depth information about specifically what they should be doing, I think that's where a lot more of the text can come in and be helpful.
Great. Well, thank you again for that great presentation. Great thesis research, Anika and Dimitra. Okay, looks like we have one other question. Anika, do you see it? I can read it out loud for everyone to hear as well. Statistics show Chinese is the most common language besides English and Spanish here in Oregon. So in your research, Anika, did you come across any efforts to translate COVID-19 information into other languages other than Spanish and English?
Yes, that's a great question. While my project did focus on Spanish specifically, I did see that CDC and OHA both were attempting to translate their documents into Chinese and also some indigenous languages, but it was less common than the Spanish translations. So that's why I said at the end that that would be a great opportunity for further research because there are a lot of speakers, definitely.
Great. Thank you for that question and that response. Okay, so we'll move on to our next presenter or presenters. I think this is a group presentation and I'm not sure who should be the co-host here. Is it you, Sarah, or Issabell?
Annalise.
Annalise. Okay, and maybe Annalise will present the group and the project title, and we'll turn it over to you all.
All right, just made Annalise the co-host.
All right, well, hello everybody. My name is Annalise Sacamano, and this is my co-presenter, Issabell Melz. And today our presentation is on COVID-19 vaccine distribution and equality, local partnership for global change. So in December 2020, the first COVID-19 vaccine was administered to a nurse in New York City. This marked the beginning of the global vaccine rollout as nations seek to administer as many vaccines as quickly as possible. While this effort has led to remarkable changes in daily life, particularly during a global pandemic, the inequalities and disparities within the rollout have become glaring. Within our group, we tasked ourselves with the following goals. Our first goal was to analyze the current pandemic situation and vaccine rollout process for each of the World Health Organization's World Health Organization defined regions, recognize the inequalities that are impeding the success of the vaccine distribution, and propose a solution to address these inequalities and create a campaign to encourage public involvement. So as our group researched the 6 WHO regions, we discovered a few key findings to help describe the current situation of global vaccine inequality. In the African region, a lack of healthcare infrastructure, poverty, and limited vaccine supply has severely impeded vaccination efforts. This has contributed to the rapid spread of the South African COVID variant, which many worry could become vaccine resistant. Within the region of the Americas, we saw the most extreme inequalities across the region as the wealthy United States has reached 39% of the population fully vaccinated, while some nations like Venezuela have only reached 1% fully vaccinated. Additionally, the US is also home to multiple vaccine producers, pharmaceutical companies, and have other resources to quickly administer doses. Within the Southeast Asian region, accessibility and the prices of vaccine, particularly for rural and impoverished villages, highlights major points of inequality for the region and abroad. This region is also home to the most severe COVID crisis in India, where rates of infection have quickly overwhelmed the healthcare system. This issue has been exacerbated by the fact that just 2.1% of the population is fully vaccinated, leaving room for additional variants of the virus to form. Continuing to look at our regional findings, our study of the European region highlighted significant challenges in the vaccine rollout, such as logistics of vaccine storage and transport, short staffing at vaccine clinics, and the issue of vaccine accessibility for the elderly and rural populations. These findings brought up the question of how these challenges and inequalities impact a wealthy nation or a wealthy region with unlimited resources, and further how these challenges would more greatly impact populations in the less wealthy global south. In the Eastern Mediterranean region, we noted that every country in this region is part of the COVAX Alliance, which we will speak more on later in this presentation. However, issues of active conflict and income equality have hampered the vaccination rollout. Finally, looking at the Western Pacific region, we see a similar situation as the region of the Americas, where there's a large income gap between nations. While some nations have had success in their rollout, such as Singapore, other nations with fewer resources have struggled. This is particularly true for the remote islands, which face not only economic challenges in their vaccine rollout, but also logistical distribution challenges like storage and accessibility. So upon analyzing our regional research and data, we discovered that the most severe inequality in the global vaccine rollout falls along the divide between the so-called global north and global south. We realized that the wealth and development status of the country played the most significant role in factors such as the ability to form deals with pharmaceutical companies, the logistical capability for vaccine distribution, and vaccine accessibility. The most striking example of this divide is in which countries are currently rolling out vaccinations compared to those that have not even begun the process. Currently, countries in the global north, such as the United States, the United Kingdom, and those in the European region have a monopoly on the vaccine supply, while poorer countries continue to struggle to contain their outbreak without the assistance of COVID-19 vaccines. Upon analyzing our research further, we created a set of proposed solutions which we believe would make instrumental change in the global vaccine rollout to ensure equality. Our first proposed solution is that we urgently call for the lifting of intellectual property patents on vaccine formulas. This call was echoed by the Biden administration, which recently came out in favor of overriding pharmaceutical industry interests in the name of increased access to vaccines within the global South. We also seek to build partnerships with local health and development organizations, along with encouraging political activism on local, national, and international levels to ask leaders to assist the global South. Finally, we seek to engage and participate with the COVAX organization and facility to promote vaccine equality.
The organizations, local and abroad, our group has aimed to partner with are Mercy Corps Portland, Central Latino Local in Eugene, COVAX, Gavi, the Bill and Melinda Gates Foundation, and the People's Vaccine to bring equitable access and awareness on vaccine distribution. COVAX in particular is an alliance launched by the World Health Organization, European Commission, and France that helps to bring equitable access to diagnostic testing, treatments, and vaccinations for COVID-19. This organization relies on international participation and promises to bring vaccines regardless of income levels to participating countries. As of today, COVAX has successfully distributed 72 million vaccines to its 126 participating countries. However, rich countries continue to cut bilateral supply deals with pharmaceutical companies, which have undermined this global effort and limited supply to poorer nations. Looking back at the HIV and AIDS epidemic, we researched the economic impact and investments needed to bring treatment to low and middle income countries. Through a study done by Boston University in 2011 by Risch, this study found that a $14.2 billion investment was needed for the period of 2011 and 2020. However, this investment led to a return that saved 18.5 million life years, a $12 to $34 billion return, and these investments in antiretroviral drugs increased labor productivity, averted orphan care, and deferred medical treatment for new infections and end-of-life care. In the 10 years, the economic benefits of treatment substantially offset the program cost. Looking at the figure to the right, the black line represents the 2.5 million patients who would not have survived if the antiretrovirals were discontinued in 2011. It also indicates the averted deaths in red, the annual life years gained in green, and the total number of patients surviving from previous years in the blue bars. The main takeaway from this study is that although there's a hefty cost associated with investing in treatment, it eventually offsets and likely exceeds costs through saving millions of lives. So how much would it cost to actually vaccinate the world? In an article by Public Citizen, it estimates that a $25 billion investment would produce enough vaccines for the low and middle income countries who have not yet gotten access. Compare this to the number of profits pharmaceutical companies have seen, $32.3 billion so far. That's more than enough to vaccinate those who have not yet gotten access. And keep in mind, the production of the vaccines were possible because of the investments made by tax dollars that we all pay. So this is why our group has called for the lifting of patent protections on vaccine manufacturing technologies. This was done in 1999 when a group of NGOs and AIDS activists held a conference in Geneva on a compulsory license on antiretroviral drugs. This allowed developing countries to buy generic versions of these drugs so that millions could get access to treatment. And here we have a quote. It says that new approaches to achieving innovation and access to medicines are possible today because of the previous decade of activism that demanded a change in a way we approach intellectual property and public health. The political and civil society mobilization catalyzed by the HIV and AIDS epidemic was at the forefront of these changes. Following the activism of the HIV epidemic, our group created a social media campaign to help educate and push our local community to help get as many people as possible vaccinated as quickly as possible. So here you'll see our social media campaign that we created. We have Let's Talk About COVID-19 Vaccine Distribution Inequalities. Did you know? Facts about the global distribution. Why this is happening and key organizations involved. Racial inequalities regarding vaccine distribution. And then ways that you and I and everyone around us can help. So some suggestions we have are to schedule an appointment for your friends and family, to stay informed on vaccine myths, to offer to give someone a ride to their appointment or to schedule them a free Uber or Lyft ride, to tweet Big Pharma and tweet politicians to lift these patents, and to also continue to keep a safe distance with each other. And then finally, we have a resources slide for local and global resources for everyone to get educated. So in our project, we faced a few challenges. Not all the organizations we reached out to were responsive, and our project is very much in real time, so the data keeps changing every day. Although the Biden administration has backed the patent lifting, there's still about a year for the World Trade Organization to agree to it, and there's still a lot of hurdles to overcome. So we hope through our research and our campaign that we can encourage those around us, even those who are listening today to our presentation, that you can educate yourselves and you can participate in the fight to bring equitable access for all for COVID-19 vaccines as well. Thank you.
Thank you so much, Annalise and Issabell. So we have a couple moments now, or minutes, I should say, if there are questions from the audience or even from other panelists, you can type them in using the Q&A function at the bottom of your Zoom screen. I have a question, because I always do. How does your group intend to share those social media infographics that you've produced, or how are you sharing them?
I think our current plans, like the next phase of our project, is to, amongst our group, use our own platforms to share, but we have also considered reaching out to the University of Oregon media team and see if there's any other student organizations on campus that would be willing to help us distribute through their different media channels.
It would be good if you all are able to do that, to track your analytics and see what kind of impact you have. Then maybe you could use that for another research paper down the line. Any other questions from our gallery here, from our audience? Okay, well, we have one more presentation. Our final presenter won't be joining us today, so we should have plenty of time at the end for lots of discussion. So if you have questions, you can jot them down while our next presenter is presenting, and we can take them all at the end. So I will welcome Natalie Schnoor to the floor. And Natalie, please introduce yourself and the title of your talk, if you don't mind.
Yeah, well, hello everyone. I'm Natalie. I'm just getting my PowerPoint set up here. Okay. First off, I'd like to thank the Undergraduate Research Symposium Board for allowing me to present my research. And I will be discussing how the COVID-19 closure has affected blood pressure and functional capacity measured in meds in phase 2 of cardiac rehab at PeaceHealth's OHVI department. So first off, what is cardiac rehab? As stated by the American Heart Association, cardiac rehab is a medically supervised program designed to improve and monitor one's heart health. So who qualifies? Anyone who's had a heart attack, heart failure, angioplasty or stent, heart surgery, and other heart conditions. Risk factors for cardiac disease include being male, 45 years and older, stress, smoking, physical inactivity, diet, obesity, heredity and genetics, diabetes, high blood cholesterol, and hypertension, otherwise known as high blood pressure. As the CDC states, if you have a heart problem, cardiac rehab is an important part of your recovery. Cardiac rehabilitation can prevent another, perhaps more serious heart problem and can help you build heart-healthy habits. There are 3 phases of cardiac rehab. In phase 1, you're in the hospital and discuss the signs and symptoms of your cardiac event. Phase 2 is an outpatient phase, where patients will come in and we monitor their response to EKGs, METs, blood pressures, blood sugar, saturation of oxygen, RPEs, or rated perceived exertion, RPDs, rated perceived dyspnea, which is shortness of breath, as well as angina scores, or chest pain. Phase 2 is a 12-week duration. Phase 3 is known as the supervised maintenance program, where we monitor patients' vitals at their request. Phase 3 needs an MD referral to join the gym. COVID-19 closed most services within the hospital. With this, outpatient cardiac rehab was closed from March 17th of 2020 till May 11th of 2020, nearly 2 months. Phase 2 transitioned to telephone appointments during this time. Telephone cardiac rehab. Home-based cardiac rehab has been shown to be an effective alternative to in-person appointments. CMS, Centers for Medicare and Medicaid Services, approves telehealth cardiac rehab during the COVID-19 pandemic. Telephone cardiac rehab may be beneficial during the COVID-19 era while outpatient services were closed. Risk factors I performed research on. Blood pressure. Both the systolic and diastolic blood pressure is a major risk factor and a good measure of heart health. METs. METs allows exercise physiologists to infer how hard a patient is working and is an indicator of one's fitness level. As stated in Physical Fitness and All-Cause Mortality by Blair and colleagues, high mortality rate correlates with low METs. So with this, my research question is, did the change in cardiac rehab services on-site versus at home affect systolic and diastolic blood pressures, as well as the metabolic equivalent of TAS, otherwise METs? Methods. I used a 2-sample, 2-tailed t-test where I tested a null hypothesis that there's no difference in the means between the pre and post closure for systolic blood pressure, diastolic blood pressure, and METs. So what is a 2-sample t-test? As stated by StatTrek, a website devoted to teaching statistics, a 2-sample t-test is used to test the difference between 2 population means. Common application is to determine whether the means are equal. As illustrated in the image below, a standardized bell curve for a t-test statistic is shown. The blue shaded regions represent the p-value, the probability of an event occurring. In this case, I am testing my null hypothesis, which states that there's no mean difference between the on-site cardiac rehab population compared to the at-home population. My alternative hypothesis claims that there is a difference in these measurements. With this, it is important to consider a significance level. In my research, I use a significance level of 5%. This means if my p-value is greater than 5%, that I can accept my null hypothesis, and that if my p-value is less than 5%, that I can reject my null hypothesis. Rejecting a null hypothesis is not necessarily accepting an alternate hypothesis, but rather acknowledging how there is significant statistical change resulting in the difference of means, not just chance. What conditions are satisfied for the two-sample t-test? Random. I use the Excel spreadsheet's t-test formula to randomly sample my population. Normal. The population is 30 subjects or more. And independent. The randomized sample is 10% of the total population. Here's my data, including both systolic and diastolic blood pressures for the on-site population as well as the at-home population. And here's my data, including METs for both the on-site population as well as the at-home population. Results for systolic blood pressure. The p-value for this significance test is 0.477. What does this p-value mean? As I said before, this p-value reveals that there is no significant change in the mean systolic blood pressures from on-site to at-home telephone appointments. Results for diastolic blood pressure. The p-value for this significance test is 0.691. Again, we have a p-value greater than 5%, which will suggest that there has been no significant change in the mean diastolic blood pressures from on-site phase 2 to at-home telephone appointments. Results for METs. The p-value for this significance test is 0.228. The p-value indicates that there is no significant change in the mean METs from on-site to at-home telephone appointments. So to summarize, there are no significant changes in blood pressure and functional capacity between the on-site population and the at-home population. This data helps to validate at-home cardiac rehab was beneficial regarding systolic blood pressure, diastolic blood pressure, and METs during the COVID-19 era at PeaceHealth's OHVI department. As my research validates at-home blood pressure and METs are similar to those on-site at PeaceHealth, perhaps more patients can be offered at-home cardiac rehab. For example, patients who cannot get to the hospital could have some value in home-based cardiac rehab. Lastly, I'd like to thank my research mentor, Erin Harding, University of Oregon Human Physiology PhD student. Thank you.
Thank you so much, Natalie. Great presentation, really interesting research. So we have lots of time now for Q&A about Natalie's presentation or about any of the presentations. So all participants and panelists can use the Q&A box to type in their question. And we'll take some time to gather those questions. Per usual, Natalie, I always have questions. I loved the application of your findings to post-pandemic times and ways to reach, to find more inclusive ways to reach people that might have a hard time getting to hospital buildings. That's a lovely application of what you found. And I was just also thinking about would there be an interest in following these people longitudinally? Perhaps a hypothesis would be giving people the skills to do these kinds of exercises at home as the pandemic provided that opportunity might lead to more sustained behavior or health change than folks who go to a building and then maybe at home have a harder time keeping those habits up. Do you have any thoughts about that?
Yeah, I think that'd be great. So originally, I'm sorry, as I'm an intern in this phase 2 department at the hospital. So that's what really sparked what happened when they were closed? Did patients get worse, or did they get better, or did they sustain, their progress with cardiac rehab? And so I really used my research mentor, who is the head of cardiac rehab. And I went through all the charts and, patients who went through the at-home progression of cardiac rehab had no significant change, as my presentation revealed. And so just having a phone call with the patients and discussing, their diet, what medications they're taking, and going over exercise that they could do, for instance, even just stretching after a light walk around your neighborhood, proved to be very effective. So at-home cardiac rehab is a very nuanced progression for cardiac rehab.
Great, thank you.
Then we do have one question in the Q&A. For the group on vaccine distribution, if someone tells you that getting rid of COVID-19 vaccine patents will hurt the economy, what are some key points you would respond to them with?
That's a really good question. I think something that our group reflected on was how as more people are vaccinated and the pandemic will more quickly subside, as currently the virus is transmitting from person to person really quickly through people who are non-vaccinated. And we realized that as more people become vaccinated, they'll more likely to have lifting of restrictions. And so our economies can reopen sooner. As we see here in the United States with the growing numbers of people becoming vaccinated, a lot of states are feeling that it's safe enough to reopen the economy and reopen local businesses. So while it is some detriment to the pharmaceutical companies as they're giving away their rights to the patents, but at the same time, there will be long-term economic value in having more people healthy and back out in the world and kind of more contributing to the global economy.
Yeah, and I also wanted to add that the $32 billion that was estimated, this is pulled from 9 billionaires that have profited from the patents. So think 9 people or the whole world. I think, yeah, in terms of that kind of estimate or like that kind of comparison, the economy is going to benefit more than the 9 people.
Thank you. Other questions? We have plenty of time. So any of the attendees that would like to type in their question in the Q&A box. I also think panelists, if you'd like to just ask each other a question, that would be fine too. Okay, there's another question for that same vaccine group. So maybe when you answer it, you can also show your video if you don't mind. The question is also for this group on vaccine distribution, did you typically find larger vaccine access disparities between WHO regions or greater disparities within a single WHO region? That's a great question.
Yeah, that is a really good question. I think a lot of our research was pointing to larger inequalities within regions. A lot of them, part of our struggle with our data was how the WHO groups these regions. So we found that there were a lot of regions that had some countries that were highly developed and had a lot of wealth, and some that were not. So we found that there was a lot of inequality between nations within a single region. So for example, the Americas region, We can see that Canada and the United States are in a very different situation with vaccines and with what medical resources they have than a lot of countries in South America, despite being in the same region.
Thank you. Anything else in response to that question? Okay, and feel free to continue to type in your questions. We can go till at least 3 p.m. We actually had 3:15 as our stopping time, but we were short a presenter. So we don't have to go the whole time, but we have the time. I'm going to ask another question to, I'm going to pose the question to Anika, but it's related to Dimitra's project. So either of you might want to take this from the different perspectives of your research. Anika, I was just curious if you noticed any particular messaging around testing last year that you thought was particularly effective. And then my second related question is, if you were to advise a health authority at the state or local level like OHA, how could they track the effectiveness of infographics that they're putting up on the website? How can they know that these messages are reaching the populations they intend to serve? So it's a two-part question. The first is, did you notice any messaging around testing in Spanish that you think might have worked? And the second is, how do we know if these massive health communications campaigns, how do we know if they're having their intended impact?
Yeah, I think both of those are really great questions. For the first one, it was slightly disappointing because I did see very few documents about what to do while waiting for a COVID test and what to do if you receive a positive COVID test. But at the time that I did my research, they had not yet been translated to Spanish, which is really unfortunate. But kind of like I talked about in my presentation, a lot of the documents, there was kind of a lag on them being translated. So I don't know if they were translated after I'd stopped collecting resources or why that was. And then for the second question, I think it's really difficult to determine if documents are actually being helpful and helping the population. That's part of why I think it would be important to look at who's actually accessing those resources or what are more common ways. I know that you had mentioned in your research presentation that one of the most common ways is the radio. And so my thesis advisor and I had talked about, would these documents be presentable in that kind of format, just reading them on the radio for more people? Yeah, that's a great question.
Thanks, Anika. Dimitra, do you have any thoughts about, since you followed so closely OHA's testing strategy, if you could call it that, do you have any thoughts about how OHA might have designed testing related information, not just for Spanish language communities, but other language communities in Oregon? And if you want to show your camera while you answer, that would be great.
I would love to show my camera, but I don't think I'm allowed to start my video.
Oh, okay.
But yeah, that is a really great question. I think one of the things that I didn't really touch upon as deeply in my presentation is the Oregon Health Authority's communication on, their communication to, I guess it was mostly targeted towards healthcare providers about who should be tested. So I found that messaging was very inconsistent and not completely clear. And part of that was from the Oregon Health Authority's perspective. They wanted, things to be flexible for providers, but in the end, that was also something that contributed to inequitable access, because different providers, different areas were setting up different protocols about who was going to be prioritized for testing. And so that led to a lot of differences in access geographically and in different types of spaces. And so I think that in terms of clear messaging, I think there's a balance between how much legal authority is given to the Oregon Health Authority, and also how much they want to take on. I did find, like, I think it was a county in California that had actually took legal action to say that providers in certain hospitals had to provide tests to certain groups of individuals if they requested one, whereas that wasn't the case in Oregon. And so I think that, like, that's one way, in addition to communication, that can help reduce inequities. But I also think that, yeah, just in general, improving communication involves a clear idea of, of what the state, who the state thinks should be prioritized. But of course, that's also subject to, changing knowledge. So for instance, with COVID-19, how significant pre and asymptomatic transmission was, isn't something that was recognized as widely early on in the pandemic.
Such great responses. Any other questions for our panelists? I can use the Q&A function there at the bottom of the screen. Do the panelists have questions for one another, for each other at all? Y'all are shy with your questions. Well, I'll ask one final question to the whole panel, and anyone who wants to respond can take it. And that is, you all had this amazing opportunity to use, a global pandemic, which surely had a tragic toll on human life and societies, but you were able to use it as an opportunity to gain some research skills and experience and knowledge and insight. And I just wondered if you have any general reflections on that. You didn't know when you started at the U of O that your final 2 years would be marked by a global pandemic, but you've been able to do these projects coming out the other side. And I just wondered if you had any reflections on that opportunity that the pandemic presented to you as young researchers.
Yeah, I guess I could start off by answering. I think that's a really great question. I definitely remember when, back in March of 2020, when, everyone started realizing that this is something different and something big that was happening that would affect people for a while. I remember thinking, oh, this is something that I think it'd be valuable and interesting to conduct research on. And I don't know, from my perspective, I think that some sort of large global pandemic is somewhat inevitable at some point in the future. So, I think even if it didn't happen last year, this year, it would have happened at some point. So I think that, I think it's a really great opportunity for everyone to, us as students, to conduct research and also to share that with others and say, look at these lessons that we can learn. And we have, all of this knowledge now that we can use to improve upon how we move forward and what we do in the future. So I think that that's really valuable.
Thanks, Dimitra. Other thoughts from the panel?
Kind of jumping off what Dimitra had just said, as a freshman at Oregon this year and going through the pandemic and seeing all the changes within, medicine or cardiac rehab with what I did, it was very interesting to go through patients' charts and see the raw data, because you see a number and you're like, oh, this is definitely going to show me that, patients are declining in their meds and blood pressure. But after running the statistical analysis with my research, it really shows perspective of, you can't just look at the data and say, oh, this changed. Because in reality, research really gets to the, real gut of it all to shine the light.
Thanks, Natalie. Amazing that you were doing this research as a first-year student. Great job. Anika, did you want to say something?
Yeah, I think that for my research project and everyone else's as well, because COVID was so prominent in the news, it brought forward a lot of problems that already existed before the pandemic. Like for my project, language barriers in healthcare already existed and already were a large issue. So it's unfortunate that it took a pandemic to bring it to the forefront of like the media. But I think it's something that, like Dimitra said, will continue to be important and will continue to be a topic of discussion.
Thanks, Anika. Anyone else? Any last thoughts before we conclude this afternoon? Issabell, go ahead.
Yeah, I work at the vaccination center, so it was really cool to see, I saw like the everyday day-to-day like vaccine distribution, but to see it on a global perspective as well. I hope that our research can just provide lessons and what we learned from the HIV epidemic. I'm sure another pandemic's going to happen again. So yeah, it was really cool to research something that's very relevant to this day and age. And yeah, 40, 50 years from now, like who knows what kind of changes we'll see and what kind of new approaches we'll have to combating a new pandemic. But yeah, I enjoyed it, and I enjoyed listening to everyone else's presentations as well.
Thanks, Issabell. Well, it was lovely to be with you all this afternoon. Thanks, Nicholas, for your technical support for our webinar. And at one point we had quite a nice gallery of attendees, maybe some parents and family members and friends. I appreciate so much the time that you all spent in this research, and appreciate your research mentors, some of whom I think also dropped in on the session this afternoon. And it was a great panel to listen to and be a part of. Congratulations to you all. So with that, we'll conclude. Thank you.
Thank you, everybody. As a reminder too, all sessions for the Undergraduate Research Symposium are recorded and will be posted in the coming month to the UO Undergraduate Research Symposium YouTube channel as well.
Great, we can share those later on. Thank you, bye-bye.